Thanks very much for the invite. I've been asked to talk about anticoagulation in AF, but actually I'm going to cover a little bit more than that because AF's pretty interesting, but the anticoagulation is not that interesting. And what I wanted to do is talk to you about AF as I would talk to a patient and how I explain AF to the patient, because there's a lot of psychology in AF. There's a lot of emotional involvement because it's a cardiac condition, and actually the time you take to talk to the patient, explain what's going on, saves you a lot of time and tears later on down the line. And the challenge that you've got is that I've got 20, 30 minutes to talk to the patient, whereas many of you have got no more than 10. And so you have to sort of pitch the discussion to the patient and compress things and expand things according to that particular patient. But in general, I'm going to try and get through the key messages that I give to patients to make them understand what's going on and what choices they have about their treatment. And we'll focus primarily on anticoagulation, but also the other aspects of their care. I'm going to start with a case presentation and talk about their care, and then we'll reflect back on general management. So I've got no conflicts of interest for the purposes of this case. So this is a 65-year-old overweight, obese female who presents with an irregular pulse at their usual medical, and they don't have symptoms. Can I pick on someone to tell me what the ECG shows? Does anyone want to volunteer what the ECG shows? So it shows AF. Anything else that you can see on there, apart from the AF? Yeah, so there's a couple of ventricular ectopic beats, and these are of no significance. So everyone gets ectopic beats. They're not a marker of disease. They're not an indicator of risk. So they can be ignored, and patients can be reassured about those. But we see that the patient's got an irregular pulse. There's no obvious P wave on the baseline, and the rate is, pretty well controlled. It's not desperately fast. And that may be one reason why they're not getting symptoms. So the minute I see this ECG, I'm then beginning to think about my 3-point plan for their AF, which is in green, the potential prognostically beneficial therapies, and in blue, the therapies that are useful for symptoms and quality of life. So stroke prevention is undoubtedly prognostically beneficial in many patients. Rate control may be prognostically beneficial in some patients, and there's still no proof that any form of rhythm control has any prognostic benefit. And we'll drill into that in a little bit more detail in a minute. So this is what I try and get across to the patients. The first is that the atria are called the atria because they're hallways for the blood to flow through to get to the ventricles. The ventricles are the things that keep you alive. If you buy a heart from a butcher, you can see your finger through the atria. And when the atria do contract, half the blood goes back into the lungs because there are no valves to stop the blood going back into the lungs. So the contribution of the atria to the cardiovascular output is really small. And when you go into AF, you get this chaotic activity in the atria, and the only connection between the atria and the ventricles electrically is that AV node. And the AV node, of course, has to get your heart rate up to 200, 220 beats a minute, because that's how fast you need to go to get maximum cardiac output. And that's normal, that's physiological. But it won't allow beyond that. So what that means is that chambers that keep them alive are firewalled from the chambers that don't matter by that connection there. So whatever happens up here, it can't kill you. Now, obviously, there are some exceptions like Wolff-Parkinson-White syndrome, but you don't need to go into that because we know that patient hasn't got that. Their ECG's QRS is normal. So every day, our hearts will go up to 150, 170 if we're exercising. So the heart's designed to do that. So just because it does it during AF doesn't mean that's any more dangerous than when you're running on a treadmill. And the difference between you and the ventricle is that the ventricle doesn't know you're exercising, it just thinks it's business as normal. So the reason that you as a patient are frightened is because you know you're not exercising. But for the heart, that's fine. It doesn't know that. So the final thing that I talk about is stroke and stroke risk. And one of the challenging things to get across to them is that we used to think that AF is the cause of stroke because blood stagnates in the atria, forms clots, and flies away to the brain and causes a stroke. Now we understand that it's not as simple as that, because if you get rid of AF, it doesn't seem to have any impact on the risk of stroke. So it may be that AF is another risk marker and not just the cause of stroke. So whatever rhythm you're in, it doesn't matter, your risk of stroke is the same. And that's important for patients because every time they go into AF, they may think, oh, I'm going to have a stroke. And actually, no, they're at no more risk then than they were when they were in normal rhythm. It's all about their CHA2DS2-VASc score, which we'll talk about in a second. Why do I have AF? Well, AF is not a thing that is caused by things. It's a probabilistic thing that we're all capable of having as mammals. And it's a design flaw of the mammal heart. And there are things that make it more likely to happen, like being a mammal. So racehorses often get put out to stud because they have AF. There's obviously a genetic element in everything. It's not strong in AF, but it is there. Age is another one of the factors that is out of our control. The older you get, the more likely you are to have AF, such that 10% of people over 70 have AF. The things that are in their control, in order of importance, is weight, alcohol, exercise, but not caffeine. And I'll show you some more slides at the end if we have time just to describe that. So my number one priority is obviously to talk to them about why they have AF and what they can do themselves to improve that, and to talk about their stroke risk. And the CHA2DS2-VASc score is the one that's currently being used. It's really simple, and the acronym just helps us to understand what those risk factors are. And you'll all be more than familiar with that. What is really interesting is that how high that risk gets at relatively low CHA2DS2-VASc scores. So even at a CHA2DS2-VASc score of 2, that gives you a 2% risk of stroke per year, 20% risk over 10 years, 1 in 5. So surely you'd want to protect yourself. Oh, well, I'm a bit worried about anticoagulants because I'm worried I'll bleed. Okay, were you okay taking an aspirin? Oh, yeah, I'll take an aspirin a day. Boom. So when you compare the novel direct oral anticoagulants to aspirin, the bleeding risk is actually pretty similar. There's no statistical significance, but the stroke rate is markedly lower if you take a direct oral anticoagulant. And patients, when you pitch it like that, you can buy an aspirin over the counter at the chemist, but you have to prescribe a direct oral anticoagulant, and yet the risks are pretty similar. So there's a perverse bias that patients will be more comfortable with that than they will an oral anticoagulant. So in practice, I don't bother with bleeding risk scores. I know you're meant to, but in practice I don't, because frankly every one of these bleeding risk scores are also risks for stroke. And so I do a CHA2DS2-VASc score, and if their CHA2DS2-VASc score is greater than 0, at the moment NICE says, discuss and can recommend this to the patient or give them some encouragement. But if it was me and I had a CHA2DS2-VASc score of 1, I'd take stroke prevention. If they have a CHA2DS2-VASc score greater than 1, i.e. 2 or more, I'd really encourage them to do that, because 20% over 10 years, that's a pretty high risk that's more than halved by taking one of these drugs. Direct oral anticoagulants have some contraindications or can be difficult in renal failure, extreme weight, extreme age. So there's a paucity of data in some patients. So for example, women, only 38% of trial populations were women, so they're slightly underrepresented. Extreme obesity, only 9% were in trials, so we don't really know what the impact of these oral anticoagulants. And the average age in most of the trials was 72, and of course we're all dealing with patients who are much older than that. So we don't really know what the data is, but my impression and experience is they do just as well as anyone else with these direct oral anticoagulants, the elderly. There have been some meta-analysis published recently to try and look at whether one anticoagulant is better than others. One recent one suggested that the trial data shows that apixaban is superior to dabigatran and rivaroxaban. However, and there's no data on edoxaban really, it's still relatively newer. However, we all know that compliance is an issue, and it's much easier to take a once a day than a twice a day medication. So I suspect that these data are probably not trustworthy because they're all taken from trials where patients were really closely supervised, and the reality is you give them the medication and off they go. And so I suspect that they're probably just as good to have a once a day drug than a twice a day. The only catch is that rivaroxaban is better absorbed with food, so if you don't take it with your meal, you may not be getting the same dose. So I think we tend to overcomplicate anticoagulants. I say you're more likely to bruise, you'll bleed for twice as long if you cut yourself, but you're no more likely to bleed than if you're taking an aspirin a day. And frankly, most people would rather have a bleed than a stroke, because most of the time you can recover from a bleed completely, which is difficult to recover from a stroke completely. So and do anything you want. Ski, play rugby, accept that you'll get more of a bruise and wear a helmet when you ski, but you can do anything you want. The second priority, which I'm just going to delve into AF as well, if I may, heart rate. So anything lower than 110 beats a minute on average is okay, because when you go beyond 110 beats a minute, that begins to cause some dysfunction of the ventricle. Interestingly, though, if you lower the heart rate, the ventricle recovers. So the capacity of the heart to cope with high heart rates is enormous. So it will have to be higher than 110 for weeks or months, and if you lower it, it recovers. So patients don't need to worry about their heart rate being higher than 110 for a few minutes or a few hours a day. Otherwise, how would we run marathons? How would we do exercise for long periods? Our heart likes that. It doesn't want to be kept slow all the time. Bisoprolol is probably the best overall rate controlling drug, but it has side effects. So my next port of call is Adizem, because it causes less constipation than verapamil in my experience. And so if patients are getting lethargy and tiredness, it may not be the AF, it may be the drug. Switch them to Adizem and see how they get on. And it's fine to combine both if you find that one doesn't work, as long as you titrate the doses up gradually. I don't use the digoxin. Rhythm control, there is conflicting evidence as to whether this has prognostic benefit. The original cardioversion trials where they used antiarrhythmic drugs to try and hold people in normal rhythm showed either no benefit or some harm, maybe because the antiarrhythmic drugs were causing risk. There was a trial called Cabana which looked at ablation to see whether ablation had a positive impact. And they cheated because the trial was designed to look at intention to treat, and they had a lot of crossovers in the non-ablation arm into ablation, and then they analysed it by treatment, and only then was ablation beneficial. And of course, it may be that simply the patients who were most likely to benefit from ablation were the lower risk patients and were crossed over. So the community, the EP community, still has doubt that ablation, or indeed any form of rhythm control, has prognostic benefit. East recently compared all types of rhythm control with rate control in quite a large study, and they showed that early rhythm control did have a prognostic benefit, but no one really understands why this should be, given that previous studies have not shown anything like this. And many of us think that this is probably related just to the fact that patients were getting more follow-up and closer follow-up than they would have been if they were in usual care. So what do we do with our patient just to remind you, she's 65, she's asymptomatic, and she's got a ECG showing a decent heart rate. So stroke prevention, yeah, I'd probably give her a DOAC. I'd probably give her, even though she's overweight and female, because I'd rather her be on something reliable than something that she finds hard to take and doesn't go to the anticoagulation clinic. Rate control, probably not, if her heart rate on average on a 24-hour ECG is lower than 110. And the only question is, does she have symptoms? And sometimes the problem with AF is that symptoms are insidious, they creep up on you, and you forget what it was like to be in normal rhythm, because all of the symptoms of AF are exactly the same symptoms of getting older or having COVID or having been locked down for 2 years. And so sometimes cardioversion can be helpful as a cheap way of trying before you buy, trying sinus rhythm before you have to buy it with a more complex intervention. And so cardioversion can sometimes give a patient the chance to feel what it's like to be in normal rhythm for a while before they make a decision about committing to something more long-standing. So if she's not asymptomatic, then it's really important that she understands that there's no point in doing rhythm control if she doesn't address some of the other factors, most importantly, weight. Long-term antiarrhythmic drugs or catheter ablation are then her choice. I'm just going to go back, because I think this is probably of more interest to you, about the factors promoting AF and what the evidence for those are. So you remember there's 3 out of our control, there's a few in our control. And let's talk about alcohol. So alcohol has a sort of linear association with AF, and the general advice I give to patients is if you keep it to below 15 units a week, then the impact it's having is pretty small. And the reason for that is I want to try and find a compromise with the patient. I don't want to say, you can never drink again, because in many patients that's not realistic. So I think 15 units is where the sort of curve begins to go up, because they're getting hypertension and other cardiovascular risks, and still the impact on their AF, the relative risk is still pretty small. And I want to be in partnership with them and make them trust me, not think I'm being unrealistic and making demands that are unreasonable. If they can't reduce their alcohol, I'll often say to them, look, do you really want to have rhythm control? Because you're going to go through the risk of these drugs and procedures, and your long-term outcome is not going to be great. So do you really want to put yourself through it? You might be better off just staying in AF and getting drunk every day. Obesity and AF, well, there's a very strong relationship between obesity and AF. And if you're successful in intervening, it has a really dramatic impact. So in this study from Adelaide, you can see that they had 2 groups, the controls and the group that they did intensive intervention. So this isn't even relating to their successful weight loss. This is just whether they intervened with diet, physio, exercise therapy. And you can see that their AF burden dropped by 50%, which is really higher than most drugs can achieve. So it's a very, very profound impact, but quite difficult to achieve. Often people are told not to drink coffee, and you can see from this study of nearly 250,000 people that the more coffee you drink, the lower your risk of AF. So there's no evidence that coffee or caffeine has an impact on AF. Now, some patients feel that it does, and that's fine, that's personal to them, but a general edict of saying you've got to give up caffeine is not helpful or doesn't have any evidence base. Final couple of slides. Rate control, this is why I say 110. This is a study where they compared strict control to lenient control, and strict was 80 or less beats a minute, and lenient control was 110 beats a minute, and there was no difference in their risk of mortality, heart failure, any of the primary outcome measures. And so the risk of going below 100, much further than lower 110, is you're going to give them side effects. So we aim for 80 beats a minute if they've got symptoms, but if they've not got symptoms, anything below 110 is fine. I've talked about the rate control and explained that I don't use digoxin. Exceptions to step 2 being rate control are if they have a reversible cause of AF. So if they've had thyrotoxicosis or a chest infection that's now gone, it may be reasonable to convert them back to normal rhythm because the trigger has disappeared. So that may be reasonable not to just stick with rate control. The second is if they have heart failure associated with AF, so heart failure starting at the same time as AF, or the heart failure gets worse with the AF and doesn't improve with rate control, then there's very strong evidence that rhythm control, getting them back to normal rhythm, has a prognostic benefit. And in A&E, because it's quicker for them to cardiovert them and kick them out than to slow their heart rate and kick them out. So that's why they wanted the ability to do rhythm control in A&E rather than rate control. For rhythm control, I offer it if they have symptoms despite good rate control. And pill in the pocket is where they just start a medication when they have the AF and stop it when the AF stops. It takes an hour for it to work, so it's only good for patients that have relatively infrequent AF that lasts more than an hour. If they have AF that's more frequent or irritating them, then regular medication or catheter ablation is the way forward. And many patients will now jump from this to this, particularly if they're younger, because they just don't want to spend the rest of their life on a medication. And the headline is that ablation is more effective, but no one's proven that it's any safer than medication. So whatever the patient chooses is fine. With regard to medication, if they've got a normal heart, fleconide's the best. Ischemic heart disease, then you can use sotalol. But unfortunately, if they have structural heart disease or heart failure, you're really limited in what you can use, amiodarone or dronedarone. Cardioversion is pointless unless you're using it as a symptomatic test, because it recurs, the AF recurs within a year in most people, because you're not changing the reason they had AF in the first place, you're just resetting the heart. If you add amiodarone, then it's a recurrence rate of about 40%, but all you're really doing is kicking the problem down the road. You're not really solving the issue. However, if they're very elderly, then it's fine to try cardioversion and leave them on amiodarone in the long term. But there's no point in doing it. I would always cardiovert them on amiodarone if I could, to give them long enough in normal rhythm to feel what it's like. So using amiodarone just helps to hold them in normal rhythm for long enough for them to get an idea of their symptoms. Useful info. So if you search North Central London DOACs, I've put DOC there, but it's DOACs. I find that actually a really good guide to DOAC prescription and who I can and I can't use and who I have to adjust the dose on. That's my website, which has quite a lot of patient information. It has a video of us doing an ablation on the front as well. So, in conclusion, it's always the patient's making the choice. You will know that the patient will get a bit angry that they've got this condition and they want to have a fight with the doctor and blame the doctor. And it's just a case of explaining and pushing back to them. It's up to you whether you have stroke prevention. These are the facts. We're happy to help you, but it's your choice, not mine. I'm not going to push you into having stroke prevention if you don't want it. Remember, AF isn't dangerous, so you slow it down and you're safe. If you have a stroke prevention, you're safe. And then the question about whether you have rhythm control is purely about how much of a pain in the arse the AF is to you and how much risk and inconvenience you're prepared to go through in order to get rid of that pain in the arse. And if it's not troubling you, leave it alone. Thanks very much for your attention.